Hello everyone. In this session, we are going to take the MCQs of gynecology, right? So obstetrics we have already discussed. Now today I'll take gynecology MCQs. Now the very first question was about an definition actually, and that was the definition of abnormal uterine bleeding in accordance with FIGO. Right, so this is, in short, it is written as AUB, right? So abnormal uterine bleeding, and as per FIGO, okay, loving heart, okay. So okay, now here actually the traditional definition what we used to teach students, it was like the normal duration of cycle is somewhere like normal duration is taken as 28 plus minus 7 days, right? So that was the conventional concept which we used to teach students, and based on that the value it was like something like this, right? So this was the usual thing which we teach students, but as per FIGO there is slight change in this, right? So FIGO says that if the frequency of blood flow happens at more than 38 days, and this is what is known as infrequent menstruation, then it is an abnormal uterine bleeding, right? So as per FIGO, we don't go for this 35, we take 38 days, right? So if there is a gap of more than 38 days between the two cycles, or the onset of menses in two cycles, then it is abnormal uterine bleeding, right? So that is what you need to remember. But otherwise, conventionally we always used to teach like 28 plus minus 7 days. So either 7 minus 28, that is 21, and 7 plus 28, that is 35. So previously it was like if there is a gap of 35 days between the onset of menses in two cycles, that was taken as abnormal. But as per FIGO, this value is 38 days, right? So as per FIGO, this value is 38 days. So the number of days from the first day of one menses to the first day of next. So if the period between the onset of two menstrual cycles is more than 38 days, then it would be mentioned as abnormal uterine bleeding. Clear? So this is a concept which needs to be remembered, and the answer is not 35 days, it is actually the period is 38 days. That differentiating landmark is 38 days, right? So please remember. Then next question was about effect of inhibin. Now as the name suggests, inhibin, so it means it inhibits some hormone. So the name itself suggests the action. So there is inhibition of some hormone, and I think most of you would answer it perfectly, that it inhibits FSH, right? So it inhibits FSH, and here it is very important to remember that, yes, loving heart, you are absolutely right. So it is important to remember that this FSH, which comes from anterior pituitary, is promoting the release of, right? So it is promoting the release of inhibin from granulosa cells of ovary. Clear? In females it is promoting the release of inhibin, but this inhibin inhibits the release of FSH from anterior pituitary, right? So this is the usual cycle. FSH promotes inhibin, and inhibin inhibits FSH. Clear? So that is in short, right? So if you take the axis, this is the anterior pituitary, right? And then the FSH, it is acting on the granular cells of the ovary to release inhibin, right? So this is stimulatory, and this inhibin is in fact inhibitory for release of FSH from anterior pituitary, right? So this is the usual axis. So this is positive, that is stimulatory, and this is negative, that is inhibitory. Clear? So please remember this. Okay, so nothing much to discuss in this particular MCQ, and it was quite a straightforward MCQ, and of course repeated number of times, right? Now third question was about the human papilloma variant which can cause carcinoma cervix, right? So I think again this is a very easy question, and most of you must have marked it right. So there are many, like 16, 18, 31. So the answer is all of the above, right? So there are many variant, and of course yes, the 16 and 18 are the most important ones, right? So for carcinoma cervix, if you can just have a look at the list, you can find many. So 16, 18, 31, right? 33, 35. So plenty of. Okay, loving heart, no issues. You can just skip this question, right? So this is in relation to carcinoma cervix, and you can just take this 6 and 11 for condyloma acuminatum, right? So you can just remember these two at least out of all the list of human papilloma virus conditions, right? So anyway, we can skip this, not an issue. Now there was another question about tandem radiotherapy. So tandem radiotherapy, and any idea what is this tandem radiotherapy? Yes, anyone? Now this is actually a type of brachytherapy. Clear? It is a type of brachytherapy, and we know that in brachytherapy we keep the radiation source close to the tumor, right? So the radiation source is kept close to the tumor, and that is brachytherapy. And okay, great. Thank you, loving heart. So tandem therapy is a type of brachytherapy where we keep the radiation source close to the tumor, and it in cases of especially related to carcinoma cervix, you can say it is a type of intracavitary brachytherapy, right? So what we do, so this is actually for carcinoma cervix, right? So this is for carcinoma cervix, and yes, you are absolutely right. So what we do, we use two things. One is the tandem. Now this one is the tandem, okay, and then there are two opioids. So these are the two opioids. Clear? So this is how we do intracavitary brachytherapy for carcinoma cervix. So this actually is the tandem here on the right side, right? And these are the opioids which are placed into the fornices, right? So these opioids, they go into the fornices, and the tandem, it is inserted into the uterine cavity. Clear? So this is for carcinoma cervix. Clear? So this is tandem radiotherapy and a type of intracavitary brachytherapy for carcinoma cervix, right? Then another question was about the location of Bartholin duct. So it was about the location of Bartholin duct. Yes, anyone? Bartholin duct, or you can say the opening of Bartholin duct more appropriately. Now these Bartholin duct are actually the it's the duct of Bartholin gland. Okay, Bartholin abscess. Okay, no problem, no problem. So it's actually the duct of Bartholin gland, which is, you know, responsible for lubrication, right? So to understand the anatomy of Bartholin duct, suppose if this is labia minora, and at its junction with the hymen, especially at this point somewhere here, this is anterior 2/3 and this is the posterior 1/3. Clear? So this is the junction of labia minora with hymen. Clear? So this is actually the location of the opening of the Bartholin ducts, right? So this is the opening of Bartholin duct. So the answer would be posterior third of labia minora, and actually it is the junction of the anterior 2/3 with posterior 1/3 to be more appropriate. And somewhere here we have the Bartholin gland, something like this. Okay, so these are the Bartholin glands, and sometimes if there is obstruction of these ducts, right, so obstruction of the duct, it can lead to Bartholin cyst, which may get infected and it might form the Bartholin abscess. Clear? So this is the usual pathology, right? So again, if you can see here, these are the Bartholin glands. Okay, so these are the Bartholin glands on either side, and this is the Bartholin duct. Okay, so this is the Bartholin duct, and it is the junction of labia minora. So this all is labia minora actually, right? So this is all labia minora, and this is all labia minora, and the place where it joins with the hymen, so this is, you can say, the hymen, right? And again you can see clearly the junction is the point is the junction of anterior 2/3 and posterior 1/3, right? So this is the usual or normal anatomy of Bartholin duct. And again, this is a very favorite question. Many times we have question from this particular segment, either in terms of anatomy or Bartholin abscess as such, right? So this is Bartholin duct. Now then there was another question about the medical termination of pregnancy if it happens because of the failure of contraception. So what is the maximum time limit till we can do MTP if there is contraceptive failure? I think it's a pretty easy question. Most of you must have marked it right, I guess. Yes, anyone? Maximum time period till which MTP can be done if yes, the answer is 20 weeks, right? So here it is again very important to note that now, as per the new rules of 2021, the maximum limit for MTP is 24 weeks, but this is only if the pregnancy is because of rape, right? In usual cases like OCP failure, the usual time period is still in practice. So for OCP failure, or you can say the contraceptive failure, it has to be terminated till a period of 20 weeks, not beyond that, right? And even after 24 weeks, MTP can be done if there are some congenital malformations and if the doctor advises for MTP, right? So in that case, we can go even beyond 24 weeks. But for pregnancy which has resulted because of rape, we can terminate the pregnancy till 24 weeks. So for this particular question, I think the answer is 20 weeks. And yes, loving heart, you are absolutely right here, right? So this is the amendment which has been done in year 2021, and here the termination for survivor of rape, this is 24 week, but in cases of failure of contraceptives, it is still 20 weeks, right? So this is important in terms of the period of MTP for the cause or the reason behind it. Okay, so please remember this. Now there was one more question, and it was about early postpartum copper T insertion. Early postpartum copper T insertion, or copper T, or you can say IUCD. Clear? So early postpartum, what is the time limit? Yes, anyone? Early postpartum. Yes, anyone? For early postpartum, it is 48 hours. Okay. So for, yes, perfect. So early postpartum, it is 48 hours. Now here, see, post means after, partum means delivery, right? So we have different options when we are going to put IUCDs, and based on that we have different nomenclature, right? So one is immediate postpartum, right? This is also known as post placental. This is also known as post placental. So as the placenta is delivered, you can insert the IUCD, right? So that is immediate postpartum, and this has to be done within 10 minutes, right? So as soon as the placenta is delivered, insert IUCD within 10 minutes. So that is immediate postpartum. Now if someone asks you about early postpartum, right? So early postpartum IUCD can be inserted till 48 hours, that is second day of delivery, right? So early postpartum till 48 hours. Now there is one more term, and that is late postpartum. So that period is from 48 hours till 4 weeks, but this is not recommended because there is high rate of expulsion, right? So higher rate of expulsion of the IUCD. So this late postpartum is not recommended. What is recommended? Either you do it just after the delivery of placenta, that is immediate postpartum or post placental, or you can go for, so this is immediate and this is early, or you can go for early postpartum, that is still 48 hours, right? Then we can do an interval IUCD insertion, and that is after the period of puerperium, right? So, and we know that the period of puerperium is 6 weeks. So we can insert the IUCD after puerperial period, that is 6 weeks, and this has got low expulsion rate, and therefore it is preferred, right? So low expulsion rate. So these are actually some terms which you should know: immediate postpartum, early postpartum, late postpartum, and interval IUCD insertion. Clear? So this is the nomenclature, and based on that you should know the specific time period: 10 minutes, 48 hours, 48 hours to 4 weeks, and beyond 6 weeks, right? So the nomenclature and the time interval when we can insert the IUCD post delivery or postpartum. Clear? So this is all nomenclature based question, and again you have to be very specific in your terminology, then only you can answer this. It seems easy, but only if you know the concept, right? So just make sure that you know all these terms proper. Now next question: best contraceptive for postcoital contraception, right? So postcoital contraception, anyone? I think this is again a very easy question, and I am very sure that all of you must have marked it right. Anyone? Very good, Vinay, very good, very good. Loving heart, absolutely right. Now this is postcoital. Coital means the sexual activity, okay? And here we are specifically talking about the unprotected activity. Clear? So what we can do, if there is although the chances of pregnancy are only 8%, right? So these are only 8%, but still we need to give contraception, that is known as emergency contraception or postcoital contraception. So right, so we need to give emergency or postcoital contraception, right? And here, yes, we prefer LNG, which has to be given within 72 hours of the act, right? So we have to give it within 3 days. So 72 hours, you can write 3 days. And we have two options. Either we can give 0.75 mg, so 0.75 mg, then a gap of 12 hours, and then again repeat 0.75 mg. So this is one way in which you can give, right? Or else you can give the entire dose at once. So you can give the total 1.5 mg at once. So the choice is yours, right? So we have these two options: either give 0.75 12 hours gap, then 0.75, or just give 1.5 mg stat as a single dose. So this is LNG for emergency or postcoital contraception, right? So this is again one very important question. Now this time there were a lot of questions from contraception, lot of questions. So if you have read that topic properly, I am very sure that most of you must have marked it right? So now I think this is quite easy to identify, and I am very sure that most of you must have marked it right. So if you look properly, you can see two S kind of appearances, like this is one S, okay, and then this is another S, okay. So you can say two S kind of appearance. So I think everyone can identify what is this. Yes, this is a typical Lippes loop, right? So this is Lippes loop, and this is non-medicated, right? So this is non-medicated, and therefore it is also known as inert, right? So it is okay, option was Lippes loop. Okay, fine. Okay, then we can put Lippes loop as one of the options. So this is Lippes loop. It is non-medicated or inert. It creates a foreign body kind of reaction, and that hampers with the implantation process, right? So this is Lippes loop. And as far as medicated IUDs, these are actually the copper Ts, right? And then hormone are all LNG and all, right? So this is a classical Lippes loop, which is inert plastic. Please remember this. And then of course the shape, I think everyone can identify. This is double S shaped, right? Nowadays it is, out of the practice. We don't use it anymore, so it is out of the practice, right? Now we come to clinical questions, and again starting with one IUCD based clinical question. So a young lady has intermenstrual spotting, that is slight bleeding between the two menstrual cycles, and this was noticed within the first month of IUCD insertion, right? So it was noticed within the first month of IUCD insertion, and there was no other complaints. Now, as a doctor, what you should do? What will be your approach here? She is a young lady and is between two cycles. She has a slight spotting, that is, you can say some slight bleeding, and this is very important here. So what you will do now? See, in such a case, whenever we insert IUCD till 3 months, we can expect slight bleeding. Clear? Okay, right. So one of the option was antibiotics and observation. Okay, so you can write here antibiotics and observation. Then another option was iron and observation. Okay, iron and observation, right? And what about option A and B? Any idea what about option A and B? I think B must be there, somewhat related to removal of the IUCD. That has to be one of the component of the options. A was not there. Okay. So we can remove the option A, because A is included in both the option C and D, right? So yes, A can be removed, and instead of A we can B was there. Yes, B has to be there, because some people might think that if there is some bleeding because of IUCD, so why don't we remove it? But in practicality, we never remove IUCDs once it has been inserted, and we tell the lady that, see, till 3 months we can have, you will have some amount of bleeding, and that is normal post IUCD insertion. So don't worry, we will keep you under observation, and yes, we can start the lady on iron supplements. So I think this becomes a better answer, and I guess option A must be like some ultrasonographic evaluation, maybe something like that. It has to be like, right? Yes, B definitely, B has to be here, because just to confuse student, because many might think of removing the IUCD, which is the cause of this bleeding, right? But in practical grounds, we never remove the IUCD. We leave it as such. We tell the lady, see, till 3 weeks this is supposed to come, this is somewhat normal, so don't worry for that. So I think iron and observation becomes a better answer here, right? So this option D is the answer if these are the options as such. Okay, thank you, Loving Heart, thank you. So you made it quite easy for me to define, right? So there is possible bleeding between menstrual periods. So right, so this is what is known as intermenstrual bleeding, right? So this is the same word, intermenstrual bleeding, and the time limit I already told you that first 3 months we need not do anything. We have to just assure the patient that, see, this is a common occurrence. It happens after IUCD insertion, so don't worry for that. Yes, and we can start her on iron supplements as well. Clear? So this is one of the commoner side effect of copper T or IUCDs, you can say. Clear? Right. Now, moving forward to the next question, and here a young lady has irregular menstrual cycle, hirsutism and acne. She is difficulty getting pregnant. It means there is some component of infertility as well, and there is acanthosis nigricans, which is actually a darkening of, or you can say hyperpigmentation of the skin of folds like axilla or neck. Then there is elevated serum testosterone, and there is insulin resistance, and USG is shown. What can be the diagnosis? I think the moment you find these much amount of clues, okay, this was not there, so we can cut it, not an issue. We can just cut it, but we can just take little words for this question, and because this is again one from a very important topic, and that is, I think most of you must have already got up to the diagnosis, that is PCOD, right? So we can just take an opportunity to just discuss few lines about this particular condition as well. Yes, loving heart, you are absolutely right. This is PCOD or PCOS. And what is important here, you can see there is hirsutism, there is acne nigricans, and there is insulin resistance, right? And there is elevated serum testosterone. So if you remember one term, which is actually hair and syndrome, there is one term which we usually associate with the PCOD, and that is hair and syndrome. So HA is for hyperandrogenism. Clear? So we can find that the testosterone levels are high. Then IR is actually insulin resistance, okay? And third, AN is actually acanthosis nigricans. So please remember hair and syndrome. Clear? So this is hair and syndrome. So please remember this. Right? So this is one word. And then again the answer is PCOS. And just to show you the classical ultrasound of PCOD, you will have a necklace appearance, right? So this is the necklace appearance, because you have so much of cystic spaces all around, right? So all cystic spaces, so this gives a necklace kind of appearance. Okay, so this is for PCOD, right? So since, yes, absolutely right. So since it was not there in the question, so it is not there in the paper, so I won't go for further details, but this is what I just want to share with all of you, right? Chalo, next question. Now, procedure of choice for a nulliparous woman having uterine prolapse but without cystocele. Now, nulliparous means she had been pregnant never, or she doesn't have a child who has crossed the period of viability, right? So nulli means zero, parity means a pregnancy which has continued beyond 28 weeks. So pregnancy which has continued beyond period of viability, that is 28th weeks. So if we say nulliparous, it means she might have been pregnant, but the pregnancy has never gone beyond 28 weeks. So this is actually P0, right? So P0. Now she is having uterine prolapse but without cystocele. Without cystocele. Now what is this word cysto? Cysto word is actually urinary bladder, right? So this is urinary bladder, and cele is actually cavity or collection, you can say. So there is no prolapse of the urinary bladder, which usually happens through the anterior vaginal wall, but she is having uterine prolapse. Now she is nulliparous, so we can presume that her priority is childbearing, right? So she want to have childbearing functions. to be retained, right? So we cannot remove the uterus. So childbearing function has to be retained. Yes, Shirodkar, very good. So yes. So sling, if not, if you have Shirodkar, you can go for Shirodkar's sling operation. Yes. Right. So what I mean to say that sling operation has to be done. So Shirodkar sling operation. Right. So in nulliparous, go for sling operation. So a nulliparous prolapse without cystocele, we need to do sling operation. It can be Shirodkar, it can be Prundare, or also known as cervicopexy, right? So this is the sling operation which has to be done in nulliparous prolapse without cystocele or rectocele. Clear? So this is in short, and this is again one very important question which has been repeated over the years. Now next question, and I am not very sure whether this question was there in the exam or not, but I have included it. So let me know if it was there in the exam or not. So there is an elderly lady, and then she had a feeling as if something is coming out of her vagina for few years, and then there is some pelvic pressure and discomfort, and when we examined that lady, we found something is protruded out per vaginum. Okay, we can just simply exclude that. Okay, so this was also not there in the exam. And again, this is a case of genital organ, or what you say, uterine prolapse. Clear? So you can simply see that the uterus is coming out, and you can also see a decubitus ulcer, right? So if you see here, this seems a decubitus ulcer, right? So this is ulceration over the prolapsed part, and if the lady is so old, it's better you just remove the uterus. So won't go in much discussion. This is again a genital prolapse, so we can just skip it, right? Now this is how we can talk about the degrees of uterine prolapse, right? You see this is the level of cervical os, right? And lower down, this is all vaginal cavity, and the uterus is just above this. Now in stage 1, some portion of the uterus descends into the vagina, right? So some part of the, or you can say till half of the vagina, there is descent of the uterus. In stage 2, the entire uterus descends into the vagina, but it does not come out of the vaginal introitus, right? So the entire vagina is filled by the uterus. In stage 3, we can see that some part of the uterus has finally came out of the vaginal introitus. So now it is in the external, it has moved out of the body as such. And in stage 4, the entire uterus is out of the body through vagina. So these are the different stages of uterine prolapse, or also known as genital organ prolapse, right? So these are the different stages of uterine prolapse: 1, 2, 3 and 4. Then I'm not very sure whether this question was there or not about stage 3B of carcinoma cervix. Is this question was there, like FIGO stage 3B carcinoma cervix? Was this question there in the exam? I'm not very sure about this question. Okay, it was also not there, so we can just remove it. But for the time being, we can take, because carcinoma cervix is again a very important topic. So what is stage 3B? Now in stage 3B, there are two possibilities. Either the tumor has moved to the parametrium. So suppose if this is the uterus with cervix, and then this is the parametrium, right? So the tumor, it has reached up to the parametrium, right? So this is stage 3B. Or there is one more possibility, that it has involved the ureter, and this results in hydronephrosis. Okay, so two things: either parametrial involvement up to pelvic wall, or hydronephrosis because of involvement of uterus. So this is stage 3B, and for stage 3B we initially give chemotherapy with cisplatin, which is followed by radiotherapy. So that is known as chemo radiation. So just for stage 3B you can remember this, chemo radiation, right? So stage 3B is invasion of the pelvic wall, side wall, or hydronephrosis, which is secondary to, this is secondary to involvement of ureter, right? So this is stage 3B, and here we do chemo radiation. Firstly we will give chemotherapy, and that chemotherapy will sensitize the tissue to the effect of radiotherapy. So that is chemo radiation. So anyway, that since this question was not there, so we won't go in more details, right? So that is all what I have for gynecology for you. Now again, if you have any queries, you can just drop me a message on my WhatsApp. And for tomorrow 10:30 p.m. I'll take a short subject. So tomorrow I'll take orthopedics, right? So see you tomorrow 10:30 p.m. and thanks everyone for sparing your valuable time with me. Good night.